let's talk now about the cardiac cycle. And the cardiac cycle, what we'll try to see, we will try to put all of the information that we learned so far into one big process. Okay? And to understand this, we need to understand a few other things before that. Some terms and some concepts. The first two terms that we need to understand are the systole and the diastole. Systole, it means contractions. Diastole, it means relaxation. And this is for both atria and ventricles. Atria and ventricles. Okay? So both atria and ventricle will get their own systole and they will get their own diastole. Remember, atria will contract left and right, contract and relax at the same time. Ventricles the same. They will contract and relax at the same time. So this is one concept. The second concept we need to understand that atria and ventricles can't systole together. What does it mean? It means they can't contract at the same time. Otherwise, our heart will explode. Okay? However, they can relax at the same time. That's fine. Relaxation wise is okay. But contraction, no. If one is contracting, one group is contracting, the other group is relaxed. Okay? That is a must. We cannot do other than this. Okay? We can't have two systole in the atria and ventricles at the same time. The third thing, which is more of a concept regarding a term that we are going to use, which is isovolumic. Isovolumic. And to understand this, we need to think of two chambers, chamber 1 and chamber 2. Okay? Both are sitting beside each other. Both they have a door. Okay? That is a door, which can open and close, like the valves. Okay? It can open and close. I'll draw it closed. So this is when the valves are open. Those are when the valves are closed. Both of the chambers, they have the same volume. But when they are closed, they are isolated from everything else. Okay? And they are also not connected together. So there is no connection between them. Okay? So those chambers, sometimes they have an exit and sometimes that exit is closed. This is exactly like the ventricles. Sometimes the AV valve are open and putting blood there, but sometimes the AV valves are closed, right? And the same thing for the semilunar valves. Sometimes they will open, sometimes will be closed. But what does this mean for the ventricles? That we will get sometime, there are brief moments when all valves are closed. The semilunar valves and the AV valves. When those valves, all of them are closed. When all of those valves are closed. When this happens, we will get those two chambers in isovolumic situation. So that's what we call it, isovolumic. Isovolumic, it means two chambers isolated from everything else. Okay, two chambers with same volume. The ventricles, both of the ventricles will hold the same amount of blood. Okay? So those we have two chambers that they are closed, isolated from everything else, and they will hold the same volume. That is what we'll call it, the isovolumic. Okay, so let's go back to the cardiac cycle. For the cardiac cycle, there are three big steps. The first one is isovolumic relaxation. That is the term that we were talking about. Then ventricular filling, and then ventricular systole. So we said isovolumic, two closed chambers, two closed ventricles. At this point, they are empty. Okay, and relaxation, or the heart is in diastole. What does it mean? Both atria and ventricles are in diastole. This is the area after the T wave. Okay, this is the area between the T P segment. Okay, now we need to understand why the valves are closed. The AV valves closed because no enough blood to open them. Of course, no enough blood in atria. The blood will keep coming to the left and right. But remember, when we talked about the AV valves, we said they will open because of the weight of the blood. So here, we don't have enough blood to open them. That's why they are closed. What about the semilunar valves? Semilunar valves are closed because blood is trying to go back to ventricles. Remember when we said that those will open here, Those will open. We'll come talk to this. Those will open because of the pressure in the ventricles. But when the ventricles relax, the blood will try to go back and it will hit those pockets of the semilunar valves. And that's why they are closed. Okay, so that's why both of those ventricles are isolated from outside and all of the valves are closed. Different reasons, but the result is the same, that all valves are closed. So now, the second step, which is ventricular filling. We are filling the ventricular. The ventricular filling, as the name suggests, now we have blood moving or moves into ventricle. Okay, this means the AV valves are open. Why? Because of there is so much blood to open them. Still, both atria and ventricles are relaxed at this point. Okay, sometimes they will say ventricular filling A, and then there is the ventricular filling B. But here it's just the ventricular filling. Okay, now the semilunar valves are closed for the same reason, and still both atria and ventriculars are relaxed. Then we will have the atrial contraction. This is a sub-step. Sometimes we call it sub-step of the ventricular filling. Atrial contraction. Here the name is suggesting that we have contraction or systole in atria. Of course, ventricles are still relaxed. Of course, AVV valves open, semilunar valves are closed. But why do I have atrial contraction? Think of it, I need to fill those ventricles with the maximum amount of blood I can. So kind of like, I will push a little bit more blood. Think, for example, you are bagging something and it's filling the box, so you'll try to push it to add more stuff into it. That's exactly what's happening. So that is the atrial contraction, which is a very short period. Atrial contraction is very short, okay? Most of the time, it's the atria is in diastole. In systole, just this period. So now, once we are filling the ventricles, we will move to the second isovolumic, or the second biggest step, which is isovolumic contraction. Again, isovolumic, it means ventricles closed, okay, or isolated. It means all valves are closed or closed. Why? For different reasons again. AV valves, okay, can't open because no room, so there is no more blood we can put in, plus no enough blood in atria. Okay, all of this in the isovolumic contraction. Semilunar valves closed, no enough pressure to open them. This pressure has to come from the ventricle. Okay, so we don't have enough pressure to open them. That is isovolumic contraction. So all the valves at this point again are closed. From isovolumic contraction, we will have the ventricular contraction. The ventricular contraction, which means now we start to have contractions, okay, at ventricles. This is very short period. That is when we start to see some contractions from the apex at the heart, at the apex of heart. But still not enough to open semilunar valves, okay? But then we will move to the ventricular ejection. This is the main step, ventricular ejection. So here, ventricular or ventricles contracted or contracting. AV valves are closed. Now they are closed because the act of the chordae tendineae. Remember the chordae tendineae that will hold those flaps in place to prevent them from opening the other direction. But importantly, the semilunar valves open. Why? Because pressure or blood pressure from ventricles is more than blood pressure in aorta. That is when we get the semilunar valves open. And that is when we have the ventricular ejection. So here we are ejecting blood into the aorta and into the pulmonary trunk. And this is the ventricular systole. After that, the ventricles will relax and we will go back to the isovolumic relaxation. So those are the steps of the cardiac cycle. You need to be able to understand and articulate what's happening in every step and try to match it with the progress of the ECG. And notice something, that the progress of ECG is always ahead of the actual contractions. Okay, always ahead of the actual contractions. Okay, let's go back to the slides and we'll show you a few things, then we will stop. So this is again the ECG with the actual events of the cardiac cycle. one cardiac cycle involves atrial systole, atrial diastole, then the ventricular diastole, ventricular systole, and ventricular diastole. Technically, the cardiac cycle, we'll call it a cycle. We'll start considering it cycle from the second we have atrial systole. From the second that the atria would start to contract, that is one cardiac cycle. This is how we overlap the ECG with the pressures in the atria and the pressure in the aorta. So this is the ECG, this is phase 1, phase 2A, 2B, and phase 3. Okay? So what I need you to notice that here, for example, we have the volume, and here we have the ventricular volume. This is the amount of blood in ventricle, and this is the ventricular pressure, the blood pressure in the ventricle. Okay? And this is the aortic pressure, the pressure in the aorta, whereas this is the atrial pressure. So here we are during this phase, we are gaining volume in the blood. So this will be the phase 1, the ventricular filling, right? So here we are increasing the volume of the blood, then that is stable. Okay? Here the blood pressure in the ventricle still low, but once we have the QRS complex, that's when we have the ventricular contraction. Okay, see the pressure in the ventricles, it will go up. At one point it will exceed the pressure in the aorta, the red line. So that's when we have the ejection, but soon it will drop back to 0. And see the volume of the blood, of course, because we have the ventricular ejection. The ventricular ejection. We are sending blood out of the ventricle. Then we will start over again. We are building blood, or we are adding blood to the ventricle. This is the time for atrial contraction. See the pressure in the atria would increase in this region. Then it's stable. Then it will drop to correspond with the ventricular ejection. See the pressure again will go up, it will exceed the aortic pressure, and it will drop. So this is how we overlap both of the ECG and the cardiac cycle with other information over one big diagram. And this is, that will try to match the mechanical events with the progress of the action potential and with the progress of the cardiac cycle. Okay, last few things. We have the heart sounds. The heart sounds are typically for closing the valves. We have two sounds, S1 and S2. The S1 is for the closing of the AV valves. The S2 is for the closing of the semilunar valves. Usually the AV valve will close before the semilunar valve. So we have the laptop sound, okay, for the heart. And technically the two AV valves and the two semilunar valves are not closing at the same time. So technically for a trained nurse or trained cardiologist, they should be able to hear four different sounds of the heart closings. Okay, that's why when they will try to move the stethoscope when they do the examination, trying to listen to the all valves for the patients when they are closing. Then the last thing is the cardiac output, which is measurement for the amount of blood pumped by the heart, okay, or by the ventricle in 1 minute. So how much blood each ventricle is pushing, and technically we're mainly talking about the left ventricle, how much blood is pushing per minute. And those cardiac output, what is controlled by the heart rate and the stroke volume. Heart rate is the amount of beats per minute, and the stroke volume is the amount of blood pumped in one beat, by each beat. Okay, usually we're talking about 5.25 liter per minute. If you remember, the blood volume is around 6 liter, okay? 6 in males, around 5 in females, okay? So we're talking about the entire amount of blood pumped each minute. But the cardiac output, there are several factors that will affect it. We have several factors that will affect the heart rate, like age, hormones, fitness levels. We have several factors that affect the stroke volume, heart size, fitness, gender, contractility, duration, the time for contraction, the preload, the amount of blood in the ventricle, the amount of blood remains in the ventricle. The ventricles are not going to empty 100%. There is usually around 50 milliliter of blood always in the ventricle. We can't drop beneath it. Okay, so that's the afterload. There is also the resistance, how much we have, resistance in the blood vessels in the systemic circulation. Anyway, all of those factors will contribute to the stroke volume, and the stroke volume changes here or changes here will, of course, change the cardiac out. So that's it for this chapter. This is a big chapter, so please go over it and let me know if you have any questions.